I forgot to, okay. So welcome to our first session of educational sessions. We loved the presentation from Gregory. So for this session, we have Dr. Christy Henzel and her team. I'll let everybody introduce themselves. If you were able to join us last year for the forum, we had a panel of, let me start my video actually. Okay, so if you were able to join us last year, we did have a panel of persons living with spinal cord injuries talk about navigating relationships, online dating, the social parts of relationships. But this year we have a different presentation on sex and intimacy after spinal cord injuries. So Dr. Henzel and team, thank you so much for joining us. Let me stop sharing so you can, where is my stop? Am I sharing my screen?
I see it says sex and intimacy. Yeah.
Okay, perfect.
It says you're viewing Meg Hammond's screen. Okay.
I think you have to go up to the middle at the top, maybe to unshare.
Mm-hmm.
I can't, oh, pause share. There. Okay, does that allow you to?
Not yet.
Yeah, the very top of the screen, maybe.
There,
Right where it says,
there's the button.
I'm
sorry,
right.
the button was hiding from me. Okay, so now you guys should have all of the controls.
Okay, so I just wanted to introduce the team. They contacted me to do this talk, but I never do this talk by myself because sexuality after spinal cord injury is such a multidisciplinary topic. So I have recruited Shua Hoffman, who is a psychology intern and will finish his doctorate in psychology, I think, this year. And Jeremy Holt, who is an OT working with me at the Cleveland VA Spinal Cord Injury Center to collaborate on this talk. And so we're going to go ahead and get right into it. And Shua Hoffman is going to lead out.
Oh, great. Thank you very much, Dr. Henzel. So this topic requires a lot of flexibility, which I understand, and I know could be a lot to expect of a group that experiences paralysis. So the good news is that because I don't have much tone, I can be folded up to fit in a FedEx box. But I just want to talk a little bit about myself so that you know that I've got some skin in the game that the other members of my team don't. I've experienced life on the other side as well, which means that I had a spinal cord injury myself 14 years ago, and I have a C5-6 injury, and that was in 2007. It was only in 2008 that I met my wife. And it was in 2012 that we had our first child, and we have 4 kids now. And I think that is important for me to own that piece here, because all those difficult conversations that I had to have with myself, and of course with others, but that's a big piece of this. So I want to just put a fix in place, how important it is to just be flexible about exploring this with yourself and with others. So sexuality is a big concern for everyone after spinal cord injury. Sexuality is different, and we got to know about it. We need to know what we can in order to ask the questions about the next steps. So keep in mind that sexuality pertains to intimacy within relationships, and it's our need to express ourselves as sexual beings, as that's the human experience. And it's how we demonstrate closeness. That's how we experience closeness, and it's how we experience pleasure as well. So it's important to know that it's questions have a place. Questions throughout the lifespan have a place for everyone, and that's what we're going to talk about today. So why don't you go to the next slide, if you could, please, Dr. Henzel. I don't see where we're at.
I thought I did, and it's not advancing. So let me try something else. My apologies. I'm just going to stop the share and reshare and see if I can get it to work again. So it's a bit odd. Normally there are no problems with this.
Well, just on the topic of flexibility, here we are. We got to hang in there.
Okay, so let's see if I can get this. There we go.
There we go. Okay. So when it comes to sexuality is an avenue. It's a channel for us to create intimacy. And a vital component is communication, which we're going to talk a whole lot about. It has a medical component, and there are also cultural pieces. So it's what I started with in the introduction about how important it is to have those conversations with ourselves. All of these areas are important, especially knowing where do we come from? What are our beliefs about sex? What do I need to challenge? And what do I need to be flexible about? And what's important for me to stick to? So, sexual adjustment after a spinal cord injury is a long-term process, and it's different. Different doesn't mean bad, but it's similar to just the first time anyone has a sexual experience with someone else. So when you think about all of that discomfort and the anxiety and how am I going to talk to this person, there are so many more things to talk about than just about what goes where and how am I going to get over my own insecurities. So let's go on to the next slide and we'll continue talking about the themes here. So it's important to note that challenges with sexuality after a spinal cord injury are not unique to anyone. But the majority, or almost all I would say, experience changes and have to figure them out. So as we see over here, when it comes to men, 80% regain erectile function within 2 years after a spinal cord injury. And it can look so bleak immediately after that injury, and it can be really hard to be patient and see what develops after that. Both for men and women, 50% report experiencing an orgasm after a spinal cord injury. So there is a future that needs to be explored. As we see over here, and these things will increase with time. So we have to be curious and be flexible with ourselves too. Have that self-compassion. So when a person experiences a loss of any sort, whether it be a loss of a loved one or loss of sensation, loss of function, those are real losses, and sexual function is included. It's right there. It is a real loss. And it's important to think about what sex can be, not how can I have sex the way I had before. It has to start with communication. What is my role? What is your role? If I already had a relationship with someone I was having sex with before my injury, well, what needs to be changed? I shouldn't expect myself to change just like everyone else does. Of quote unquote, just like everyone else, but rather what is going to be my experience? Because everyone's is different. So if you want to connect with other people, that first conversation is going to be about you. Self-image, especially that body image, our associations as a world really focus on our physical experiences and our physical sensations and our physical functions and how big are the muscles. I remember someone years ago said to me, wow, your calf muscles are so big, you have a CD player in there? I'm like, no, but these days my calves are not much to speak of. But there was so much of that association that I had with that physical experience. I like to jog. I would love being in the outdoors and working hard, climbing mountains. Well, now where am I at with all of that? And if I can't do what I did, and if I can't feel what I felt, where's my worth? And if I'm not feeling good about myself, that doesn't put me in a great place to start connecting with someone else. But if I can imagine feeling good about myself, then I can start not just seeing the good in them, but I can say, wow, I have what to contribute. So that is the first step to making space for this new approach to sex we're talking about here. Like, hey, things can be different. This is something that I don't want getting back to my wife, but I do remember early conversations, like, I remember tapping her on the leg, like, hey, can you feel this? Like just that association that I had, like I would get so swept up in our own experiences, and we think that's it. It's like, can I be curious about you? And that can help me also further develop curiosity about myself. This is emotionally risky because if I start telling you about, oh gosh, the plumbing's a little different down there, and like, wait, got to catheterize. Oh, I actually have an indwelling catheter. Well, what kind of catheter? Oh my catheter goes there. What's she gonna think? What's he gonna think? Oh, wow, man alive, that's a lot. That's a lot of anxiety. That's a lot of pressure. That's a lot of stress. But if I'm always stuck in that stress and I'm not curious about myself or another, then man, that's the first barrier to approach. That's the first barrier to start to tackle. But you can also tackle that challenge with the help of that person you're creating the relationship with. Say, well, how do you see me? I'm struggling with the way I'm seeing me. But give me a little insight. That can be a place too, but it can be really difficult to talk about emotions in general. But now I'm explaining, there's not much I can do over here. So you're going to have to do a lot of moving around. Right? So that's, you're going to have to, put my feet over here. Oh, put the leg over there. Oh, don't mind me. Just put me where it feels like you'd be comfortable for now, and then we'll figure out me after that. So as with so many other things, having some humor in it can be very helpful. And that goes just back to like my wife would always laugh, I'd tap her on the knee or something like that. I'm like, you feel this? Okay, I get that you can feel the head over here, but I'm just curious about you because I'm so stuck in the way I'm seeing myself. And of course, there can be pre-injury difficulties or sexual dysfunction that also has to be addressed. That has nothing to do with it, but let's go on to the next slide. And this is a real continuation of exactly what we're talking about. Can I feel great about myself? Because, hey, if my partner says that this feels good, that kind of touch feels good, that kind of, oh, put your finger here. Oh, no, all the way down. No, further in the ear, all the way. If you can do that, then wow, it's a different experience, and we can both feel good together. We can feel good after too. But it can, it's so much more challenging if I'm just thinking about, gosh, it's not the way I'd like it to be, and it's not the way that I'd like you to be doing things either. Well, so let's go on with the next slide here. When we think about sexual esteem, is different than self-esteem. Sexual esteem means the capacity to experience your own sexuality in a satisfying and enjoyable way. So when after a spinal cord injury, it just changes. What are my attitudes and beliefs about who I am and what I can give to this person? Well, what I can give to this person is different than what I did beforehand. Oh my, well, before there was a lot of just giving to me, and oh, we can make this a much different experience. Also because now I've got all these other places around my body that I can feel and that I can enjoy. I can use my sense of sight, and I can use the sounds that I hear and the places that I can touch and be touched. So that's the curiosity that I need to have. That's that communication I need to have. And partners, both men and women, love it when people communicate, when we communicate and say, you know, I'm feeling anxious about this. And then our partner will go, whew, man, so was I, but I didn't want to say anything. You know, but we're so forced into it because of our disabilities, the lack of function, the lack of sensation, and all the pain we may be experiencing. And I'm just worried, I'm concerned. How is this going to come off? But I need to do that with caregivers. And this is really important too. How do I figure this out? In creating a relationship, in giving pleasure, in experiencing pleasure. So if you could, Dr. Henzel, we'll move on. So one of the questions that's important to consider is, excuse me, what makes a good partner for someone with a disability? Well, I don't know what doesn't make a good partner, except for a person who can't set aside that head space and that heart space. Anyone who can do that for you is a person who would make a great partner. Because I can set aside the time, I can give you my thoughts, I can give you my logic, and I can give you my emotions. Putting yourself out there and finding a partner, if you don't already have one, was easier pre-COVID, but these days it's there are other ways people are figuring things out. There's social media, common interests, online dating. I heard a rather shocking story that there was someone who actually met their spouse in a bar. You know, they said, "Could I buy you a drink?" I don't know if those happen much these days, and you know, I know this is being recorded, but please don't hold me to it. I don't remember who that was. Might just be a fluke. The elephant in the room is that conversation. Wow, well, we've had a great time together. We've gone out a number of times, and my partner's pet, you know, this is the person I'm creating this relationship with, or I already had the relationship with. Well, there's been some physical touch, maybe there'll be so many comments, there have been the looks, but then we both want to take it further in this relationship with our past partner or in creating a new one. I think it's terrifying. It's terrifying. I don't know what's this person gonna say when I say that. You know, there's, of all the things that you want to experience, well, there might be a whole bunch I have to knock off the list, and it can be scary for me to say that. And what's my partner gonna think, and what are they gonna say? And oh, but then we start to open our mouths and we say, wow, well, gosh, I don't know how you're gonna take this. And our partner, hopefully it's that person who has the head space and the heart space, might say to us, well, let's be curious about this together. Let's figure this out. Maybe we should just start by holding each other. Maybe not even in bed. Maybe just finding a way to hold hands, close, taking it one step at a time. So when you consider what the other person appreciates, the majority of humanity likes that communication. And we start to ask those questions. We start to share how we're feeling. That most often will open the other up as well. So it's the first question to begin with here is, what do both partners need to know to have great sex? Well, let's just take it one step at a time. You might ask your partner, what would you like to know more about my disability? Does my disability bother you in any way? Are other people's reactions to my disability a concern for you? Are you wondering about how I feel? So those are some of those easier, however difficult those conversations may be, they're easier than that next step of, oh gosh, well, now I got to take off my shirt. And, for me, I can't say that I have washboard, what do they call it, that, washboard abs or the six pack on my abs, because that's not much to speak of there, but I do on my chest. You can see every rib because of the atrophy there. So, I don't know if they're looking for that in the firefighter's calendar, but maybe if we have, you have the spinal cord injury calendar, and you can have everyone else, can have like the OTs and the PTs, positioning all those with the spinal cord injuries, because of the paralysis, don't know. But so that's my only thought about how helpful those ribs are. But it's the fundamental question to keep asking yourself is, what can I be curious about next? And that leads us here to, what do I want or do I need sexually? Well, I don't know. Well, who are the people to speak to? Or what's your thought? Asking your partner, gosh, how do I get this message across in a way that feels both self-respecting and respectful of my partner? How do I say it? Because there's so much anxiety, but also frustration. The loss will continue to be felt. That sadness, that grief, all these emotions may be coming together at the same time. And how can I just choose to focus on the person in front of me? How can I choose to say, you know what, I want to make this connection. I want to have this relationship. Okay, how can I take that softer tone of voice? How can I ask them in a way that they want to give back? And when it comes to my partner, it's important for me to keep being curious about them, not just myself. How are you feeling about this? How does this feel to you? Do you feel comfortable to keep going? Should we take a break until next time, or that we're feeling adventurous? Maybe we need to deal with something that has to do with bladder, or that has to do with the bowels, or maybe I need to adjust my pain meds. Or maybe we shouldn't have those, what is it? The edibles right before we try this, because although we want it to loosen us up, I'm feeling a little too loopy to engage right now. So, for however you consider it, but it's also important to ask your spouse or your partner, what have you, and be open to their response, because the more that they can feel that they would like to, that they are being appreciated and they are a full partner in this process, the more open they are to being curious about you and trying this again, being curious about it, because other people mirror our own emotions and our own experiences. Is that it? Yes, go ahead.
Okay. First of all, man, great first half of the presentation. I think, your insight was invaluable. It was excellent. No one's ever commented about my calves, but I'll just carry on here.
What about your abs?
My abs? Oh, gosh.
Okay, all right.
All righty. So I'm Jeremy. I'm one of the occupational therapists here in Cleveland, VA, and clinical specialist. And I'll be kind of talking about sort of occupational therapy's role in this, whole topic. And so occupation, the first thing I want to kind of talk about, is used to mean all things we do. Physical, mental, social, sexual, political, spiritual in nature. So we talk about an occupational therapist, we're talking about somebody who should be very broad in what they do. This is just some stuff about American Occupational Therapy. What they did, they've changed and added some different things to add sexual devices to the personal device care, and through social participation, they've added that intimate partners may or may not engage in sexual activity. So I think like it's becoming more of a focus of OT, and I just kind of wanted to point that out here. So this was an interesting little piece from an article, and it says that although most of OT support this sort of holistic whole person care, sex doesn't get the same attention as other activities of daily living, bathing, grooming, and dressing. And I think like, as time goes on, I think this is becoming, more of a point in OT. But I thought just to bring it up that people are noticing that sex is an ADL and it does need to be discussed, educated, and talked about. So just talking about terminology, I thought it was kind of interesting. So the old framework, which is what OT sort of, guide our practice on, had that engaging activities that result in sexual satisfaction and or meeting relational or reproductive needs. Kind of more narrow, not really what I'm looking for. But it's changed now to engaging in broad possibilities for sexual expression and experiences with self or others. So that has a lot of key components, I think, that was left out of the old framework. The new one is starting to kind of get with the program, starting to add different things. And I think that's really good for our field. So OT's role in this, and everyone's role has overlapping, I think, features. But, my role in this is creativity. So when I'm doing an education session on sexuality, I'm trying to not only be creative myself, come up with creative solutions, but I'm also trying to help the client come up with creativity and come up with solutions as well. One of our roles also is positioning and safety to promote this sort of experimentation. And we're going to talk about a lot of equipment and things for experimentation in a moment or two. And kind of open line of communication. And that's going to kind of be, I think, a common theme through all of our presentations, that communication is really key, whether you have a spinal cord injury, whether you don't, in general in life, and especially in relation to sexuality. So the caregiver's role can be kind of an interesting one. And when we were kind of building this presentation for today, we kind of discussed between the three of us, how it can be uncomfortable and how just asking the question can be, just uncomfortable. So we're thinking, the matter of fact sort of instruction was how somebody put it. And I think that is absolutely the way to look at it. Simply stating, sex is an ADL. It's a need just like everything else. And, maybe asking the caregiver, I need you to help me undress, or, prepare for sex in this manner. Maybe donning a universal cuff with a special toy. Maybe they need to be there for positioning, certainly for skin checks, and I'm going to talk about that in a little bit later on as well. So the reason positioning is important, it's not just an anatomical marrying to be able to, engage in sexual activity, but it's also for things like protection of limbs. If you have limited range of motion, the last thing you'd want to do is get injured during, a sexual encounter. Thinking about sensation, areas that you have sensation versus ones that you don't, protecting the ones that you don't, to not only skin integrity, but also, fractures and things of that nature. Spasticity is something that can be used, advantageously in a sexual activity, or it can, cause detriment to it, just depending on how it's used. So it's something to sort of think about. How caregivers can assist, I think we kind of covered that in the last slide. Your comfort with your individual caregiver, I think, is really going to dictate, at what level they're helping. Day one of a caregiver, I believe you should be able to ask them for help. I believe most people won't. And I, obviously fully understand that as well. But I think the more you build rapport, I think it can be easier. Although sex is an ADL, you should be able to, ask for that help straight away, in my opinion. I always like to tell my patients, let out your inner OT. And maybe this is like a fulfilling sort of thing, that OTs are creative and, experimental. And, one of the reasons I became an OT, because I like creating things and that. So I like to tell my patients to kind of open up their mind, to figure out what they want, what they need, how to ask for it, and that sort of thing. For positioning, you have a wheelchair that's ideally dialed in perfectly for you, supports you the way you need to be supported, has surfaces that promote, less incidence of pressure ulcers and whatnot. It could be an option, could be a viable option during sexual activity, sex, or maybe just the precursor, or, can be used in different capacities. So some of the precautions, these go with a lot of different things, but, exertion, pressure ulcers. If you have a pressure ulcer, obviously that, doesn't mean that you can't engage in sexual activity, but you just have to use precaution around it. And so lubrication, I think Dr. Henzel might talk about this during her presentation, but I always mention it as well, particularly for women after spinal cord injury, there might be less lubrication, just less formation of lubrication. So think about adding lubrication to prevent pressure ulcers in genital areas, which are areas that we don't normally inspect for pressure, really, because they're not bony prominences. It's something to think about, and inspecting before and after. So if you're going to use your wheelchair, we're doing it because it's all about support, but there's precautions and some tips that I like to provide. If you're in a manual wheelchair, you'd want to utilize your wheel locks. It sounds like kind of maybe an intuitive thing, but I still have patients who go to transfer without putting their wheel locks on. So I thought I would just mention it as a safety precaution. If you have anti-tippers on your chair, leaving them on. If you're in a power chair, that there's no brake per se when the chair is off, it doesn't move. So having the chair off, thinking about weight limits. If the weight limit in your chair is 225 pounds, you're 100 pounds, think about, the weight of the person you're going to be engaging in activity with, and be careful of that as well. And the chair location. This is like, if you want to engage in activity in your manual chair, maybe move it into a corner of a room, maybe put it next to the sofa, maybe, move it around just to kind of optimize your positioning. So as I mentioned, pressure ulcers obviously don't make it so you can't engage in sexual activity, but you want to avoid weight bearing on these high risk areas. And we're talking about the ischial tuberosities, which are your sit bones, greater trochanter, your sacrum. And if you have ulcers, you don't want to get set up in a way that you're weight bearing over that ulcer for the entire duration, because, you just want to prevent it from getting worse. And if you're going through a session of sexual activity where maybe the whole shebang lasts an hour, you still need to maintain these pressure relief schedules, and changing positions can be a good way to do that as well. And I'm thinking that, changing the position can also be fun and, elicit, potentially more pleasure. So, pressure relief schedule can be a good thing as well. We kind of talked about that. Yep, thank you. So sexual range of motion is something that I've kind of added to this presentation. I think I've talked about it before, but so everyone with spinal cord injury should have some sort of basic range of motion program, right? Whether it be self range of motion or having a caregiver provide this range of motion. And stretch like an athlete means, before a event, athletes are stretching before and after the event, right? And I think that's important for someone with spinal cord injury. And position specific stretches. Think about the positions you're getting in. If you're a person who hasn't been in a position with maybe the leg spread, something like that for 10 years, and now you're going to do it, you're going to be sore afterwards. And I think kind of stretching before or after is something valuable and something to think about. I thought of sex athlete. I don't know if that's taken, but I thought it was kind of cool. And then, asking your caregiver maybe to provide those range of motion stretches. And also range of motion, maybe that's a foreplay. Maybe, incorporating that into your foreplay might be something that's, I don't know, kind of fun, kind of interesting, and also, very helpful. So, part of my title, I'm assistive technology professional, which is ATP. We always like to go low tech before high tech when it comes to all devices, right? And no different here when you're talking about positioning for sexuality. The advantages of using like a pillow, you can stack multiple of them. They're not going to cause pressure on a bony prominence. They're readily available, they're cheap, and they can do a lot of what some of the specialized wedges and other things can do. I've ordered a few of these purple devices for some patients, and it just kind of helps get you in an optimal position for certain types of sex positions, if that's, the type of position you're trying to do. I think most of them could probably be with the pillow, but, the purple wedge or a bolster can be a good, positioner. Also, just maybe on the couch, just maybe you looking around your house and what you have. Do you have a chaise lounge? Kind of utilizing your environment and what you already have first. Secondarily, looking at some other options. The hospital bed, it might not be very sexy, but I'll tell you what, it can get into some pretty good positions, I think, and I think it can be utilized like that. The intimate rider is a device, and there are tons of devices, and I could, just fill the whole thing with it, but, everyone's gonna have to do some exploration for the, to find out what they're really looking for. But the intimate rider basically is like the sex version of reduced effort steering for driving, basically. It gives the person with a disability is in the chair typically, and it gives you kind of a motion in the ocean at reduced effort. So it's kind of cool. I've ordered that for a few people with like, some of our multiple sclerosis patients and whatnot. So this one, some kind of fun positions up there. They're kind of tongue in cheek, but there might be some valuable ones out of there as well. But thinking about, environmental considerations, it might be, engaging, it might be sexy to try a different room not used. Maybe having slight furniture rearrangement to sort of promote this, this sort of ambiance and positional needs. Also thinking about simple things like, lighting, television. Maybe you could have a movie on that maybe turns you on, or your partner. Maybe some music, candle, diffusers, kind of just like regular stuff. And just think about, incorporating some of that. So assistive devices, I kind of updated a couple slides for this presentation. And what I found out was during COVID, assistive devices and sexual devices are on the rise. Purchasing these online has gone through the roof. So it's kind of interesting. I think it's probably good for the market and the kind of the variety of options that are available. But I guess there's never been more of these purchased than now. So I think that's kind of cool. So there's a lot of different devices that people can use, but some of the really common ones, are using vibrators, using penile rings and pumps, which I know Dr. Henzel is going to talk about as well. But they're kind of, they're used in unison a lot of times. And Dr. Henzel will also talk about the penile implants, but they all come with their own precautions. They all come with their own, you have to be careful, like not to fall asleep with a constriction ring on. There's certain things for every individual one. So some devices based on your ability. If you have limited hand function, a massager, a vibrator, a universal cuff with whatever, right? A universal cuff can hold majority of things, and you can come up with plenty of toys and different things to put in there. I think that could be fun. Fleshlight is more of a kind of a self-exploration, is this still working? Does this feel good? Type of device. Finger vibrator, maybe you have some finger function, maybe you have a limited finger function. Well, this can sort of get things going without exhaustion or, a lot of effort. Thigh rider is one other option in there. If you have no hand function, universal cuff again, stick anything in it, OT's best friend. Tongue vibrator, kind of a neat option for, oral sex, for, just it could be just general arousal type stuff. Doesn't have to be, full-blown oral sex. Furniture harness, which is actually pictured right here. No, you're good, doctor, thanks.
Okay.
And that kind of, I think, is something where, would be good if, like, maybe you have biceps but lacking hands and things, and you would like to strap that to sort of, a chair so you can kind of get some leverage and different things that might be pleasurable to you. The body bouncer right there, it's kind of a neat device that's on the market. And then down here, the sort of rainbow of all these different devices was just like, I was just getting flooded with different shapes and sizes. And I mean, if you can't find something that works, keep exploring, and have fun choosing. I think sitting down with your partner and choosing what devices you're going to order, or go to a store, of course, but there's so much out there. I think it can be a fun, exciting thing to engage in with your partner. And yeah, so through the senses, and I think that this was described so nice before my presentation, talking about, the things you can see, hear, smell, taste, touch, kind of utilizing all the senses you have, engaging your partner in all her or his senses is important as well. Now, Dr. Mitch Tepper, a lot of people might or might not know who he is. He's a sexologist, and he has some videos that, quite kind of graphic, but, it's kind of something that maybe would be good for somebody to look at if they're kind of interested about, like, how does this look? How does this go about? So check out that website if you're interested in that, or just Google Dr. Mitchell Tepper. He's all over the internet and talks at conferences all over the world. And Dr. Henzel had added this one to my slides, thank you. And I actually didn't have a chance to look it out, but sexualitysci.org, Sexuality After SCI video archive as well. So please check that out. And then a lot of my slides and pictures came from this Pleasure Able catalog, sexual devices for a person with disabilities. And a lot of the things in there, I can order a lot of them for my patients, but, in the private sector, I'm not sure how it goes, but they're not expensive, a lot of them, and I think it'd be a worthwhile investment. So check that out. And this is how I can be contacted if anyone needs to get a hold of me. This is right there. And they got married 3 weeks ago, and this is me and my beautiful bride, although the picture looks a little, thank you. Picture looks a little blurry, but that was 3 weeks ago. Thought I'd share that as well. Thank you.
Okay, so Meg, I wanted to ask you, we're at the end of our time, and so I could send you these slides or I could plow on. I want to respect the time limits. This is a sort of more of a medical approach to things. So what would you guys like us to do at this point?
Excuse me. I don't see Jen from Coloplast yet. Jen, if you are here, let me know. If you can kind of wrap it up within a few minutes, that would be great. And then if you still want to share slides, I can definitely send those out as well.
Okay, so let's plan on me talking for maybe another 5 minutes or so. I actually have an 11 o'clock that I have to get to. So, and then we'll send you later the slides that you can distribute to the attendees. So when it comes to the physician's role in sexuality after spinal cord injury, my role is less to promote intimacy and relationships and more to focus on body and organ system factors. There are a couple of different components to the sexual response. There's the arousal part, and everybody gets increased heart rate, breathing, and blood pressure during the arousal part. Males will have penile erection, females will have lubrication occur and clitoral enlargement. There are two different parts of this. One is psychogenic. That's the sexual excitement you can get just from thinking about things without touching your body. And then there is the reflex arousal that happens from whatever kind of stimulation of the skin or the hairs of the genitals. And it's important to think about, like, for men that might be embarrassed by an erection that comes out of the blue, maybe they're getting their catheter changed. Before a spinal cord injury, your brain is trained to suppress that. And or has trained your body to suppress that erection. And so, it's normal for that to happen when you don't have the ability to suppress it any longer because of your spinal cord injury. So that's one of those things you might want to communicate to caregivers. People above T10 usually have reflex arousal, even if they don't have genital sensation. And the more sensation you have between your belly button and your pants pockets, the more likely you can be psychogenically aroused. And people whose spinal cord injury is below T10, if they don't have any rectal reflexes, like if they have a floppy sphincter, then they may not be able to get reflexively aroused and they may need to look at other choices. Optimizing your physical health is really important. There's a lot of medical complications like tobacco use, cardiovascular health, diabetes, and obesity that can negatively impact sexuality. So the extent to which you can optimize your health can really maximize your sexual experience. There are a lot of physical barriers to sex after spinal cord injury, and we've addressed some of them, like bowel and bladder incontinence. You just make sure you've gone before a sexual opportunity. AD can be an issue. Unfortunately, that's probably too big of a topic for us to cover right now. But it is something to be aware of. If you have headaches, you may need to sit up and pause your activities for a moment. The medications that we use to treat spasticity and nerve pain can have a negative impact on your sexual experience. And so that's some counseling that I give to my patients, and you could speak to your physician about how you could maneuver or change those medications when you're going to have sex. We'll talk a little bit more about erectile dysfunction and lubrication. Obviously, fear of incontinence is really a big barrier to people having sex or being fearful of having sex. This is where that sense of humor can come in because, everybody poops, right? Everybody farts. And we all pee, most of us, if we're not on dialysis, right? So you just have to come up with ways, and you can talk to your physician about how to optimize that. You want to make sure to continue to take precautions against getting sexually transmitted infections. We already talked a little bit about how lifestyle and reversible factors like smoking can negatively impact your sexual experience, and particularly erectile dysfunction for men. So those are things that you may want to address. Now, those reflex erections that I mentioned are great if you get them because you can get an erection, and you know that now. That can be a negative that you can't always get it when you want to. And those erections don't always get hard enough or firm enough, and they don't always last long enough for penetrative sex. So you might need medications or tools to treat that. And so we kind of went into a little bit of this. The big medications are Viagra, Levitra, and Cialis, and these you might or might not be able to take if you're on medications like nitrate. But all of them require genital stimulation to work. They do provide a longer lasting and better quality erection. They should be taken on an empty stomach. You can split the doses to see if you can get more bangs for your buck. And it takes about 30 minutes before they'll work with sexual activity. There are some side effects. You should speak to your physician about these if you're going to get into them, using them rather. For penile rings and vacuum devices, you have to use them in combination. You would need instruction on how to use them. They do typically have a problem that they're a little bit less stable because it only engorges the tissue in the penis. It does not cause erection of necessarily the tissue, that runs underneath the body as part of the penis. You can't leave those rings on for more than 30 minutes because they can cause blood clots that can permanently damage your ability to have an erection. There are also injections, which are really highly effective, but require good hand function or a willing partner. And they typically can cause erections that'll last up to an hour. They are invasive, it requires less spontaneity, and there can be infection and scarring. So you have to be trained to use them. For women, unfortunately, there aren't any medications that we currently know of that reliably increase clitoral enlargement. But stimulation is key, and really the way to do that is with liberal amounts of water-based lubricants to avoid friction of a bad sense, meaning that it's going to break your skin down. The good news for both women and men to some extent is that there appear to be more cranial nerve connections between the brain and the genitals in women that may make it easier for them to have orgasms and may make psychological stimulation more helpful. So we do recommend doing all of that foreplay to prepare for sexual experience. In terms of, this is copy, I don't know where that came from. Anyway, so for orgasm and climax, this is an autonomic whole body reflex. It can happen even if you can't feel someone touching your genitals. And so training your body, like how we do bowel training, you have to train your body to respond. And so masturbation is helpful. And you probably are going to need a stronger and longer stimulation to trigger a reflex. So where you could have maybe used just your fingers before, you might need a vibrator, or you might need, even potentially some electrical stimulation or something. And we already briefly talked about medication timing. Fertility is a big concern for a lot of people. Men are typically able to achieve ejaculation through either home devices like penile vibratory stimulation, which is generally done in the lab first. But then if that doesn't work, we have electroejaculation. So it's similar to how they get, semen specimens from, prize horses or bulls. And that has a medical procedure that cannot be done at home. For women, it's important to know that your fertility is not significantly impacted by spinal cord injury. You'll probably miss between 1 and 6 months of your menstrual period, but you can get pregnant before that first period comes. So you really, if you don't want to have babies, you should engage in contraception. So be aware. Okay. Pregnancy after spinal cord injury can be complicated by autonomic dysreflexia. There's a higher likelihood of C-section, but we think that's often due to position discomfort rather than the inability of the body to push that baby out. So it's important to have a good conversation with your gynecologist, obstetrician. UTIs and pressure injuries can also become more common, and it can be important to adjust seating and potentially even rent a power wheelchair as pregnancy progresses. Some people do need assistive reproductive technology. That's usually when it's on the male side, but obviously females can have infertility too. And so if you have the home penile vibratory stimulator, you can do intravaginal insemination with just a 1 or 3 cc syringe, like a turkey baster. And then you can get into the medical techniques with intrauterine insemination or in vitro insemination. All right, so I ran through that really fast. We don't really have a lot of time for questions, but I do appreciate you giving us this opportunity to talk today.
Oh, absolutely. And thank you for being here to speak. That was such a wonderful presentation by all three of you. I loved the ribs comment. Ribs are the new washboard abs for the spinal cord injury community. I love it. No, lots of great tips. I mean, I took some notes, but thank you. Thank you so much for being here. That presentation was wonderful.
Thanks so much for inviting us.
Thank you for having us.
Some other time.
Yes, absolutely.
Okay. Bye, everybody.
Bye, thank you.